to begin with Maria Raven's paper.
Thanks to everybody. Thanks to Harrison for having me here. And I'm Maria Raven. I'm from UCSF, formerly at Bellevue and NYU, where I trained under Dr. Goldstein and with some other people here. And so, I mean, I guess first I want to say that I think even though we may feel like we all have a long way to go, I think our specialty has come a really long way. I remember when I was getting my MPH during medical school, which was a very long time ago, and I decided I wanted to go into emergency medicine pretty early on, and I felt like no one could understand that. Like, they thought it was bizarre that I was getting a master's in public health and kind of taking that viewpoint and wanting to go into emergency medicine, even though it made a lot of sense to me. And so I think that we've come a long way in terms of people now understand that in a lot of ways, as we've been saying, the emergency department is sort of a window into some of the societal and healthcare system sort of failures or gaps. And so it actually makes a lot of sense to take a public health viewpoint when practicing emergency medicine. So one of the, I mean, just to sort of summarize my paper a little bit, I'm not going to actually talk about it a ton, but a couple main points. Just historically, when I was sort of doing the research around this issue of homelessness and emergency department utilization, I thought it was really interesting that it seemed to me that deinstitutionalization that occurred kind of in the 1980s and before, and then kind of defunding mental health services and EMTALA kind of coincided to create sort of this perfect storm, if you will, of the emergency department being actually a really logical place for homeless individuals to end up coming for care, because there really wasn't anywhere else that they could go. And we didn't really put the infrastructure in as a society to care for people in other ways, especially people with mental health issues. And so that to me was sort of this like a light bulb that went on. Maybe other people have already realized that, but I thought it was really interesting. And I think it's sort of continued because we really, as a society, have continued not to prioritize resources like, you know, low-income housing, just in general services to take care of people with mental illness and substance use issues outside the emergency department. And so there's really not enough infrastructure. And so as a result, lots of people come to us because we're there 24/7, and we may not feel like we have all of the skills necessary to care for people, but we actually, I would argue that we have some pretty good skills and resources and connect people to those resources. And so another point I wanted to make is that it's a little bit of a pet peeve of mine. And so I don't want to get on a soapbox, but I do think that we should be careful as a specialty to use the term, not to use the term unnecessary or avoidable when we're talking about emergency department use, because especially among homeless individuals and others, emergency department use is actually completely irrational. It really makes a lot of sense. If you're an individual that doesn't have a connection to primary care, that can't really plan in advance for your doctor's appointment when you don't even know where you're going to stay that night. And so the fact that we're there and people are coming to us is more a reflection of a lack of other resources than anyone's poor decision making. So I think we have to be cautious as a specialty and really try not to use the word unnecessary emergency department use. I don't think it's a good thing for us. And from an economic standpoint, like they're actually a source of revenue for our department. So I don't think we want to push a bunch of needy people out that really need our care. And then I wanted to make the point that I talk a little bit about in the paper that a lot of the knowledge I've gained in terms of social determinants of health have happened not only in the emergency department, but actually through partnering with people outside of the emergency department. So John A. mentioned earlier that, we don't have to take on this huge burden as emergency physicians of feeling like we need to do everything. And Dr. Doran too mentioned that, Kelly mentioned that just because we ask a question about homelessness doesn't mean we have to provide the person with an apartment. There are other things we can do to help people once we know that they're homeless that make a lot of sense right then and there. And so some of the things that I've figured out sort of in my work is that, this might be a little bit new to our specialty, or the idea of thinking about social emergency medicine might feel new, but other community-based organizations and even other specialties within medicine have really been focusing their efforts on these ideas for a long time. And I think to some extent, we're coming to this a little later because we strangely are excluded from different practices. So I'll give you an example. You know, it seems like I always find out that there are, for example, programs to refer outpatients or even inpatients to buprenorphine services on site in my medical center. Yet there's nothing in the emergency department, and no one from the emergency department was asked to represent us on the steering committee that decided that, or funding from Medicaid for Prime or other things supports, let's say, tobacco cessation efforts in the outpatient setting, but the emergency department is totally excluded. And so that is sort of a structural problem within the House of Medicine and policy to some extent, but I think we have to, and we can, involve ourselves in existing efforts and kind of tag on to those a little bit more. So just the idea, it's not a new thing. Our specialty is maybe a little new to it and thinking of it as this concept, but it's around, and a lot of us have probably been doing it and practicing it, maybe without even realizing it. And then just the idea that given that, we really can do a lot more for our patients than we might realize with just, I think, a minimal amount of extra effort. And whether that comes from the ED provider or from, I mentioned, we have healthcare navigators that do some of this at UCSF. You know, I think of the emergency department as an underutilized point of intervention for a lot of patients for a lot of different things. We have each ED visit is sort of an opportunity not to just provide clinical care for the acute episode that a patient might be having, but to kind of look a little bit deeper and see, well, what is the kind of underlying reason for their emergency department, or what else can we kind of find out about them and help with that that might not only prevent them from coming back, but kind of improve their quality of life outside of the emergency department. And so to that end, I think there are certain things we can do in the ED. Like Kelly mentioned, you know, if you have a homeless individual that has a pneumonia that you might otherwise discharge if they weren't homeless, maybe you need to admit them. Maybe you need to get meds to their bed so they can walk out with their whole set of prescriptions. But maybe it's also important to really make sure, because you found out that they really don't have a connection to primary care, but they have Medi-Cal or Medicaid, that you can get them into primary care. So how can we do those kinds of things? And should that be the role of the physician? Probably not, but those are things that social workers and healthcare navigators can do, especially for the patients that we see that are homeless, to kind of create more of a system of warm handoffs, email communication, other forms of communication with people outside of the emergency department. Similarly, in New York and in California, some of the interesting things that we've done is to partner with community-based agencies. So the Department of Homeless Services, you know, you can do data shares with different community-based agencies so that you know if your emergency department patient might also be sleeping at a certain shelter and you might want to get them back to that shelter. You can have teams come in that are active in the community. So in San Francisco, we have a team called EMS6 that goes in and works with a lot of homeless individuals that are frequent users of lots of different systems. They can actually come into our ED and see a patient when they're in the ED, as long as we let them know the patient's there. And so I think there are a lot of ways that we can do a lot with a little, I guess is what I would say. But it takes a lot of making inroads with agencies, with other people in the hospital. And then I'll give one last example of just coordinating within the House of Medicine. We've had a lot of success, I think, collaborating with colleagues in psychiatry, addiction medicine, palliative care, you know, for homeless patients, also for other patients, but to really work together as a team to kind of follow patients throughout their continuum of care. So I've had more than one patient where I've worked with psychiatry to kind of realize this patient keeps coming back here. Actually, no one's ever evaluated if maybe they are gravely disabled and need an inpatient psychiatric hospitalization and would actually benefit from that. And it's happened more than once. And it's led to some kind of really interesting collaborations that might not otherwise be there, but that are very much available to all of us. And I think I'm running out of time, so I will let Dr. Kaplan continue.
Thank you. Thank you so much for letting me be a part of this. So I was just talking to Dennis and Margaret, and a pet peeve of mine is the emergency department should never be anyone's first stop or last stop. So we're right in the middle. So how do we position ourselves to utilize what's outside of ourselves to really get the patients to the resources that they need? So when I started my first attending job, my mission was to create a ED-based care management program because we didn't really have anything at that place. And we came up with all of the great things we all talked about. It's the right thing to do for the patients. The providers are overwhelmed. They can ask the questions, but not really take the time to address everything for every single patient that needs it. When it gets busy, you may lose a patient or so. So how can we create the infrastructure and the support that's needed for the providers? And the response that I would get over and over again, but who's going to pay for this? And how do we get reimbursed? Because that service is not currently reimbursable. So we got very creative. We went to our partners. We went to our Medicaid office, our HMOs. We worked with our community sites because they're like, we don't hear when patients are coming to the ED. We know the ED is a central point, like Dr. Raven said, but all these resources are trying to tackle these patients are outside of the emergency department. So how do we connect those dots? So they provided us with funds, and we created sort of a hybrid care management model where we have patient navigators, social workers, and nurse case managers to be able to address the different needs that patients have. So they work in conjunction with the medical team where you identify patients, they come in and they really help and bring in the interventions. They're all community-based interventions. So we're not taking the ownership within the emergency department to say, we're gonna follow you through 3 months or get you housing and all of those things. We're really partnering with the community organizations. They're already doing that. They're great at what they do. They just want the ability to connect with the patients when they're coming into our system. And the results have been really great for both the patients, the community organizations, and the providers love it, as all of us have talked about in terms of burnout. I think a couple of things that have come up in terms of challenges are related to extending that length of stay in the emergency department when you have to provide extensive care management services, and how do we address that? As a specialty, Dr. Doran mentioned you can put them at discharge desks, and we have tried that, but then patients are too tired and they don't want to wait around. Some folks have addressed it by having a work queue list for the care manager to pick up on the Monday through Friday schedule because you cannot have somebody there 24/7. We have found that the outreach rate is really poor, that moment in crisis when they come in is really important. So I think in thinking of a research question, that would be my first question for the group in terms of really understanding, is there a difference in outcome, whether or not you can provide the right intervention to patients at the moment they walk into the emergency department, or is it okay to do a follow-up mechanism, and what does that entail to achieve that same outcome? I think the other challenge that we have run into is, you know, our emergency department is pretty busy. We see anywhere from 250 to 300 patients per day. We only have so many care managers. And so how do we risk stratify the patient population, which I believe a lot of folks have addressed this through doing some screening tools and whatnot, but how do we incorporate those social determinants of health into the population risk stratification mechanism so we can really engage the care management team proactively and very early on in addressing the issues and being able to provide the services that we need for patients.
Just one comment on that, even before Dr. Doran goes, but I think it is really interesting because in reaching outside the emergency department, one thing that I have found is that organizations, they want in, like they have no eye into the healthcare system because of HIPAA often. And so the idea that someone from the healthcare system would come and want to partner with an organization like the Department of Homeless Services, even like, you know, a Medicaid managed care organization. I mean, that's not a good example because they are healthcare, but like a community-based organization, it's really, people want to engage because we are basically a black box. Once a patient enters the emergency department and gets admitted, a lot of the outside organizations that are working with some of these individuals have no idea what goes on, and they might not know the patient's there. So anything that we can do to kind of increase that communication through use of technology or other mechanisms is super helpful to sort of everybody that's involved.
Now we're on to Dr. Doran's time.
Hi, I'm Kelly Doran. I'm from NYU School of Medicine. First, I just wanted to thank Harrison for putting this amazing effort together. Thank you. And yeah. in what's maybe a testament to sort of teaching the next generation of emergency physicians, Dr. Raven was my mentor when I was a resident and she was a faculty member at NYU, and Dr. Goldfrank has been a critical mentor for both of us. I was especially happy that Harrison asked me to write this commentary on homelessness because some of you might know, but I've been doing homelessness for longer than I've been doing medicine. I started doing homelessness-related work as a volunteer and later one of the directors at a student-run shelter during undergraduate. And I've continued to work with shelters and other homeless organizations since then. And in fact, that's why I went into emergency medicine. And I've been lucky to have the opportunity to continue my research and my focus on homelessness as faculty now. All of that to also say that I'll be the first to admit that I probably come at this issue of homelessness from a somewhat different perspective than a lot of emergency physicians, and that's my bias and I recognize it. My focus because of that is always on ending homelessness. So when we talk about things that we can do for homelessness in the emergency department or out of it, that's always my benchmark. You know, helping people, giving them food and clothes in the emergency department, providing them with the best possible care in the emergency department, to me, that's necessary, totally crucial. It just needs to happen. But ultimately, people's lives are going to improve the most by housing them. And just serving people who are homeless is noble, but it won't fix the root problem or the health inequity. So my hope for this group is that we can be a little bit aspirational about our responsibility and our ability in emergency medicine, not just to care for the individuals before us, but also to do something to help the 1.5 million people who are homeless in our country every single year. And that's what I attempt to emphasize in my commentary. In it, I talk about some of the very well accepted strategies for addressing homelessness, like supportive housing, medical respite prevention, and there are roles for emergency medicine in all of those solutions, whether it be through kind of just shining light on the harmful health effects of homelessness, to collaborating with community organizations to develop new programs, to advocating on a policy level. To start, I kind of agree with the commentaries that Dr. Raven and Cap wrote about the necessity of asking every patient about homelessness and documenting it in the medical record. There are ICD-10 codes that exist already, both for homelessness and for inadequate housing, as well as a variety of other social determinants. I want to take my remaining time just to touch upon two of the tensions that I think have already come up this morning. First, are people who are homeless using the emergency department because they're sick or because they want a sandwich? Some of the comments touched on this earlier, but in my commentary, I also talk about how I believe that in a large part, they're using the emergency department because they're sick. We know from past research that they're sicker than average. And we also have national studies using NAMSIS that show that people who are homeless have triage acuity levels and admission rates that are equal to people who aren't homeless. Sure, they might also want a sandwich, but I feel like our duty as emergency providers is to believe them when they tell us that they're having a medical complaint. I can't even count the number of times that a resident has told me the patient was just there because they wanted a sandwich, and when I insisted on actually undressing and examining the patient, invariably met with an eye roll. We found all sorts of medical needs that have to be addressed acutely. So I just want this group to come from the baseline understanding that as a whole, this is a very sick group of people that have real medical needs. The second thing I just wanted to touch on is the question of whether we should be addressing these topics and care about homelessness in particular for moral reasons and for economic reasons. You know, I think the answer is both. So economic arguments are always compelling, especially for people like our colleagues in the C-suite who might not otherwise be interested in this topic. And I'm really hopeful about new healthcare payment models and regulations that might further incentivize some of this. I've seen huge growth in this area in recent years. So United Healthcare actually has a vice president for housing right now. Massachusetts Medicaid recently started paying higher rates for their patients who are homeless. I was recently part of the National Academy's panel on how Medicare might further incentivize providers to address social determinants. So this is all incredibly exciting and on a rapid upswing. At the same time, I feel like we need to not be overconfident in our promises of return on investment for addressing social determinants of health. The truth is that there's just very little research right now that shows that addressing these determinants from the healthcare setting will actually save us money. And if it does save money, many of those savings are likely to occur in the long term, and most of our policymakers and our administrators are thinking more in terms of the short term. So I do think that we need to recognize the moral argument as well. And to me, as I've said, I think in some of the comments, it's not just a moral argument, but it's a responsibility and a duty argument. This is part of our job as emergency physicians, given how prevalent homelessness is, especially in the emergency department, and how strongly it affects people's health outcomes, including the immediate outcomes of their emergency department treatment. addressing homelessness is simply within our scope of practice. It just is. It might take a while to get all of our colleagues there, but I think that we can do it, and I look forward to further discussing with Bill.
Well said.
Well, I don't think anybody's saying, no, by no means was saying that homeless people are there just to get sandwiches. Not by any means.
Thank you.
Yeah, I'm sorry if I gave you that impression, and I don't think anybody here believes that either. But I do believe that there are times when that is a food, shelter, and safety are primary factors for their presenting. And what I'm trying to convey is that we should encourage them. We should empower them to declare those subsistence needs. Not at all saying that those are the only reasons that homeless patients present, and not at all saying that they don't have other disease. But we should absolutely encourage them to express their subsistence needs. And I think the other point that was made or that was suggested was that that teasing out those issues is a part of every patient's evaluation. Yeah, that's definitely true, but a part of every patient's evaluation, regardless of their complaint. But I do think that that there is a shame factor, and there is a sort of a social desirability influence that prevents them from declaring those needs, and it's just a barrier to our caring, to determining what they're really there for, and to so I think trying to bring those things into the light.
Just to respond, I'm going to respond briefly to that.
Yeah.
I agree. I think that one of the best ways to empower people to state some of these subsistence needs is to believe them when they tell us what they're there for, whether it be chest pain or whatever else, and to show them that we're listening to them. Having spoken to a lot of people who are homeless, most of them don't mind if you ask them about their homelessness as long as they feel that you are taking them seriously and addressing their problem. So what most people don't want is for you to immediately say, are you homeless? You really need to, if they're telling you that they have chest pain or whatever, listen to them and find out about that as you go.
He's not saying that.
No, I don't.
Yeah, both of what you're saying is important. They're not contrary to each other.
No, I think that they can both coexist. I would say I think that we need more research on why people go to the ED. I think one of the only studies is actually yours, so it's a great contribution to the literature that it's one of the only studies that asks people why they use the emergency department. But even in that study, it asks people, is this one reason why you use the emergency department? It doesn't necessarily say that that was the only reason they went to the ED. So even that 25% who said that their ED visits were motivated by food, shelter, and safety needs could have had other medical problems at the same time. So I think that that's one place we might need to go in future research, find out.
So Hemel, Jody, Steve.
Hamil Gonzaria from UCSF and SFGH. I think you guys are closer to saying the same thing, maybe it seems. But I was just going to add one error that I think physicians often make on all patients. I think there is a component of medicalization where the patient may be there for multiple reasons, and then you hear the word chest pain and you focus on that because that is what right now we're teaching our students and residents to do. And so that I think is our mistake to own and to really understand why the patient's there, what are their main medical, social, health needs, and to do our best to address all of those needs to the extent we can in that moment, and I don't want to put words in your mouth, Rob, when you say medicalizing or over medicalizing, but that is where I feel like we maybe are potentially practicing.
And you can't sorry for speaking out of turn, but you can't there's no CDR code or CD9.
There is no CD9 code for homelessness. There's one for hunger.
Is there one for hunger?
Yeah. Yeah, there's ICD-10 codes for all of
Well,
these things. But most emergency physicians don't know.
That's a useful point right there. I mean, I did not know that, and I personally have never seen that written as an ICD-9 code in my, and so that's a useful teaching point right there.
I mean, there's Z59 codes if anybody wants them. So
can you use that as a primary?
I'm
codes
not a
can't be a
biller.
primary.
Who put it in?
I just Googled it and it had said that they can only be a modifier from primary diagnoses, but yeah, it did say it's all the
It
Z59.
can't be a primary. Okay, going in order.
Yes, since we started talking about coding, how we've been talking about today, let's remember, right? Social determinants is not something that those other people have. Everyone in this room has a social determinant. We take away our degrees and all the things we have, we actually could be on the other side. Some of us have been really sick patients before and be a patient. So social determinants, we all are dealing with right now. And so when we focus on the patients who are coming to us at that point of time, let's also think about resiliency and the assets that they have, and not judging people because they may have whatever the social determinant word that they have, an ICD-10 or 9, whatever code they have, right? So they're all human. Let's talk about social determinants as something that as humans we all deal with, and then think about the resiliency and the assets that are in these communities, and not just what's wrong with them and how we can compensate for them by giving them all these resources. Sorry, I'll be quiet.
Just to reinforce that point, the socioeconomic gradient and health, the relationship between the socioeconomic gradient and health, obtains in any room, across any nation, across the globe. It is always true that the more privileged patient, the higher you are on the socioeconomic scale, the less health risks you have in any given situation. So even in this room, the socioeconomic gradient persists. So it's always there. Social determinants affect every patient encounter. I really don't think it's just the vulnerable patient, or however we're choosing to.
And just to ask that though, but if you look at disparities, me as an African American woman who makes probably the same amount of money as a lot of people in this room, I'm at higher risk for having poorer outcomes just because I'm an African American woman. You take away how much money I make. So again, just thinking about all that, again, we're focusing on the resiliency. Right, the resiliency and the assets in the community, and thinking of it from a human perspective and not just those homeless people, those substance use disorder people. We all have folks in our families, and maybe some of us are dealing with some mental health challenges or substance use challenges, and physicians having a high rate of suicide. Let's not talk about those other people as if we're not human.
We don't talk about success-based research enough, I think, looking at assets. And it's a little bit of a problematic thing methodologically, because sometimes it ignores other stuff going on in the background, but it is an interesting model, and I think people who are dreaming up questions to submit should keep in mind that success-based research, particularly in social emergency medicine, I think is going to be an important thing to look at. I think you're going to apologize.
No. Steve Harder at Medical College of Wisconsin. Just to build on the paper and the great work and the comments just made, I've been hearing about avoidable visits and unnecessary visits and then inevitable visits. I think it's really an interesting descriptor. And I typically also, when I'm perplexed about why it's not self-evident why the patient's in front of me, now a diaphoretic patient pacing with their hand clasped to the flank, it's kind of pretty straightforward why they're there. But when it's not clear, I found that asking the question, why did you come to the emergency department now? Partly as a testimony to my level of burnout that day, why are you bothering me, which sometimes doesn't seem to be a particularly urgent problem, but asking that question now is actually very, very informative. When they've had chest pain for 6 weeks, it opens up a whole order of issues that I wouldn't have otherwise thought if I hadn't asked that question, framed in a non-judgmental way. And by not being able to do it in a non-judgmental way, it affects my level of burnout. I need to take a break because I'm asking it in a pejorative way. The second piece that I think is interesting about the paper and about the framing of homelessness,
I think it should be broadened to include what's your home. You have a residence, let's say you don't have a residence, but let's say you report a residence, but you've just been evicted. There's a great book out that actually takes place in Milwaukee about, and it's called Evicted. And it's about the challenge of families being disrupted and their kids being disrupted. Those are major health issues that I think people don't quite think about when they're talking about homes, homelessness, evictus, moving 5 times during the year because it's so challenging. So I think that's an element, if you could add to your paper, to talk about that broad issue of the stability of the home environment is a good, important element that is valued for resilience and other factors that help families be successful.
And if I could, I'm Katrina, I'm one of the residents from Highland Hospital, where, as you know, we deal with housing insecurity, a significant issue in our community, and that was what I was actually going to speak to. People who are marginally housed at great risk, like who are one paycheck away from like losing their housing, like how do we also think about them and advocate them and developing resources for that population? That would be a significant burden also on the system.
That is what my NIH grant's on, my K-23. So my work right now is around homelessness prevention, because you're right, housing and homelessness is a continuum. The people with the worst health outcomes and the highest ED visits are those who are chronically homeless, and I think that's why we sort of focus our papers there. But even people with housing instability have poorer health, and it's something to address. So, my work right now is trying to develop predictive models, like PERC score or whatever, for how can we predict which patients that aren't homeless, when we see them, will become homeless, and intervene beforehand. So,
just to follow up with the fact that, and I'm struck by, I don't think this is intended, but I think the majority of the papers, and this one particularly struck a chord, is that we're generally talking about social emergency medicine in significant urban areas versus trailer parks and edgy parts of counties and so forth. So there's a spectrum, as you said, of the housing issue and challenge that crosses all geographic areas. And whether you're practicing in a relatively rural county or a large urban center, you still have some of those issues. So that's a really important element of this work.
Yeah, I think that's a really good point. And I think, when we're talking about teaching and education, part of it is too, like, how do you even ask that question, right? Like about where someone's staying. I think it's difficult to say, are you homeless? And it's easier for someone to say, no, I'm not homeless. But if you say, where'd you stay last night, or where are you staying? I think that's maybe a little bit better. There are probably all different kinds of ways we can ask these questions. But to your point too, I think until it's sort of more normalized and we're asking everybody all of these questions and not making assumptions, then it is going to feel like a little awkward and weird. And like we're kind of assuming that, the person that kind of like looks like they're homeless or looks like they have a mental health problem, if we do that, we're disadvantaging in a way, not only that population, but all the people that we're not discovering that maybe aren't presenting as obviously because we just don't ask them as a part of our normal practice. So I think that's a really good point.
Which goes back to, remember medical school when you had to ask the sexual history. Do you have sex? They taught us you have sex with men, women, or both, and you just say it with a straight face and keep running on. Right.
It's like when I asked the person with, I'm like, I'm going to ask you a couple really like silly questions right now, but I asked them to everybody. So, it's because I think that they might have dementia. And so, but I want to like frame it in a way where they won't get offended when I'm asking them what the year is or who you know what I mean? But until we start to like normalize all these things, like you're saying, it's probably not going to work that well.
At this point, and Steve's point about, why now, why today, both come back to Dr. Caldoun's point about a lot of this is just being a good doctor, and the point that Lou made earlier.
That when it's that, I don't think that's a social determinants question. That's just that. I was taught that at some point in residency. I don't know where it was, but that's how you ask the question.
Yeah.
We have Lou.
Trying to establish a principle in emergency medicine that every visit is an emergency in the patient's eye, the eye of the beholder.
Right.
And that, for example, in deference to Dr. Hoffman, that not interested in doing it a shortcut in any circumstances with any nominal decision about the person, because being homeless is another distracting injury. You could call it hexis or whatever you'd like to do. But the point would be that you can't assess the person adequately because the stressors of life are overwhelming, whatever they represent that particular day, hunger or lack of warmth or too much heat or whatever it is. And so I think it's just, you have to look at each person and do it yourself and get the history, and then you can make a decision. And there are no real shortcuts to that because you know the critical questions to ask on any particular day at any particular time. And so it's not, there's just, I think it's part of being, as I said once before, it's being a doctor, and this is a critical issue. These people have terrible problems that we don't understand effectively, no matter how long you've worked at it. It's always something different, and it means examining someone often when it could be a shortcut, but usually all people have to be examined in nude to be able to know what the problem is. And you may not worry about the fact that a guy the other day was brought in because the family next door said the guy smelled too much and had to be brought into the emergency department. So he did have maggots and he did have big trouble and he needed a lot of care, but that wasn't his complaint at all. It would have been that he's impaired from a hygienic point of view. Yeah.
I think this is a great discussion about the social history in particular. But I think a lot of it has roots in how we're trained as physicians and in medical education. And there's a great paper in the literature by Philippe Bourgeois that talks about reframing the social history that we are trained to take as a structural vulnerability assessment, and that this structural vulnerability assessment should be considered, in the treatment of all patients. And I think that also goes along the same lines of like kind of normalizing these questions and thinking of it in terms of all patients, just like Dr. Raven was saying. And the second point that I wanted to make was just about, this question of, is the homeless patient here for their homelessness versus, or, for their subsistence needs versus, for their chest pain. I think that, this also goes back to, the way that we're trained and the point that Dr. Hargarten made about the biopsychosocial model of health, and that if that was really more at the core of our medical education, then we would see these things all as more of the continuum, because, a lot of the patients, they may present with chest pain and they may be experiencing chest pain, but then when you ask, when did the chest pain start? And they say, well, the chest pain started when my husband got deported, right? And then, you find that it's actually the psychic pain related to that experience that's causing the chest pain. But, it's all part of the same human being. And we need to kind of understand that better and convey that better in our medical education system.
I step up and just say, yeah. I think that's a take-home point. Let's change the title to Risk and Vulnerability History, because we could all get in line with it. Steve Anderson, ACEP Board. And did I mention I'm the ACEP Board liaison to the social medicine section? Thank you. This is an honor. And I just wanted to say, because I think that's brilliant. But what I wanted to speak to you, the two of you, I think, are saying the exact same things, but it's a matter of it's a matter of framing the message to who you're talking to. If you're talking to the nurse that tells you that room 22 is 3 hots and a cot, or they're the sickle celler that's just back from more pain meds, your job is to explain the brilliance of your paper, that these people have a higher incidence or the same admission rate, the same ICU admission rate. They see specialists more often. They're seeing their own doctors more often. They're high risk. We need to go back in there and we need to take our good risk vulnerability history. But on the same token, we're the stewards of the healthcare dollar. And for years, we've tried to ignore that. I was never taught in my training how much a CBC costs, how much it costs to run another lipase. And there's only so many dollars to go around. I don't think it's pejorative to ask the question. I teach a class called Managing Difficult Situations, and one of those 7 is, why are you really here? I don't think that's wrong to ask, because if you're here for hunger, I don't need to scan your belly for the 4th time. I don't need to run the 15th normal lipase. There comes a point in time where I have to manage those dollars a little bit so I can find money to help with other outpatient case management resources. So if I'm framing this question to the CFO and to my C-suite, it's one set. I'm a responsible steward of the healthcare dollar. If I'm framing it to my charge nurse who just wants to kick him back out because Denny's is down the street, I need to explain your brilliant paper. Thank you.
Did we reach thematic saturation? Actually, Brina, I appreciate you bringing up, I've never known how to pronounce that guy's last name. Is it Bourgeois? I think it's missing an E, but you know, I got into this through anthropology in a way, and I forgot today how much we have to learn from them. I don't know how to bring anthropology into emergency medicine. I just wish they lived here. If anybody has any bright ideas about how to incorporate everything they've learned about the human experience that we need to know in providing emergency care, I'm all ears.
It wouldn't be a bad idea to have an anthropologist from every university linked to the emergency department. I mean, it was the anthropologists were really the heroic leaders in the effort in Ebola in Liberia and Sierra Leone and Guinea. I mean, they really understood the cultural variance of various people, how they would deal, for example, with cremation, or how they would deal with the end of life issues. So it's certainly, we have a big meeting coming up in Accra in the end of October, where it's about palliative care in the emergency department for end-stage kidney disease, because there's no dialysis and there's no transplantation. So really how to work with people who are dying, who come, the non-communicable diseases are overwhelming that emergency room. So the anthropologists are exceptionally helpful in understanding how the people's mystical belief or religious beliefs can be handled effectively without appearing abusive. And it's not anthropologists from San Francisco or New York or Texas, it's anthropologists who live in the country. And their role is critical because that's going to advance the capacity to care. It would help us. It certainly helps us elsewhere in the world, so there's no reason it wouldn't help us here. But there's a big dissociation between our use.
Yeah.
If we get an anthropologist, can we get a sociologist too? Because that's my training. I think sort of what I'm hearing, kind of putting it all together, I think we need to take back some words that get used a lot in medicine, and that's patient-centered care, right? How many times do you hear that my hospital provides patient-centered care? And nobody really knows what that is, right? But this is what we're talking about. Whether the homeless gentleman is coming in because he's hungry or because he's having chest pain or both, it's our job to find out why he's here and what he needs. And, you know, as was said earlier, we might say, oh, we can give you this great list of resources and we've got social workers that can call you. But if what he's interested today is maybe not necessarily getting into a house, but it's, you know, some other need that he has, and we are not asking that question, then we're not doing patient-centered care. And that's what we need to be doing with every patient. So I think if we start thinking about what the concepts we're talking about in social emergency medicine and communicating them to our colleagues as, this is patient-centered care, right? Isn't that what we're supposed to be doing? That's on our mission statement. That's what we teach our residents to doing. But it starts with asking the patient what they need and asking the patient what they want. We don't necessarily have to be the ones to provide all of it, as we've said, but if we're not asking the right questions, whether it's in the social history or any other part of the history, then we're not going to be providing the care that we want to provide.
Just to follow up on this, and I was talking earlier about how emergency medicine came to be. We took a lot of elements of anesthesia and trauma surgery and internal medicine, cardiology to form the substance of emergency medicine. And I'm struck with the fact that if we're going to construct the science of social emergency medicine, the entity, the subspecialty, whatever it is we're going, an anthropologist, a sociologist, a psychologist, an economist, a health we would benefit from maybe perhaps the next phase of discussions to have a diversity of leaders and thought leaders in a variety of places. We've tapped into public health as an example of we benefit from that perspective, those perspectives, those contents we borrow from these areas and form the content of social emergency medicine. I'm struck by this conversation as well as the day that we're on the move to do that, and having an anthropologist that'd be so good to have that in context with a public health leader, in the context of having a sociologist and so forth, to inform what we need to do better, in this case in the emergency department setting, but in our communities.
Great idea. Okay.
Yeah, I think language really does matter, and how we talk about things reflects how we think about things, and I think we may be getting a little lost. If you come in with chest pain and I ask you, are you short of breath? Nobody calls that a review of systems. They call that history, because it's part of the history of chest pain is knowing are you short of breath? If you come in with an ankle sprain and I ask you about are you also short of breath, that has nothing to do with your ankle sprain. That's something entirely different. I think we need to stop dichotomizing this notion that the reason we're asking is because we want to find out if they want to get here for a meal versus they want to get here because they're having an MI. It may be true that when somebody has chest pain, one person is having an MI and the other person really just wants to have a meal, or it has to do with their partner being deported. But in so much of what we do, it isn't split like that. The reason you can't deal with the emergency problem without understanding the social context of it. And for many of our patients, in order to deal with their cellulitis, you have to know where they're going to go sleep tonight. Can they take their medicine? Can they put their leg up? There are many ways in which this is much more integrated than, oh, it's an add-on. We're going to add it on to the things that we do. And I think we really need to stop talking about it as screening, as something to look for, another thing to give the doctor one more thing to do that he or she doesn't know what to do with the answer, but that this is really a fundamental part of understanding why the patient is here and what you have to do if you actually want, as your goal, to have a better outcome for your patient. The reason we're doing this, again, I think, has to be different than because we're nice people who are interested in good things. It's because there is, as we all know, as the people in this room know, but other people don't know, health outcomes are tremendously tied to addressing social needs. If we don't address social needs, we can't take care of the health of our patients. If we want to take care of our patients, that's the reason we need to do this. And so I don't think it should be a separate thing. Social emergency medicine is somehow different than emergency medicine. It's part and parcel of what we do. We have to start thinking of it that way, not as an add-on.
Right.
Okay, I agree with that. And I'm just thinking about like what we want this group to do. And I'm hearing a lot of people talking about, is it screening? Is it not? We should just be asking these questions. This is just our job as doctors, which I think is true. I also think if you want to be able to do something actionable and act on some of these things that we're talking about, let's say a patient is, close to being evicted or homeless or needs a referral to, I don't know what, something. Unless we have a way of doing a better job of actually recording it somewhere, if it's in the medical record, if it's in EDI, if it's it's going to be hard to A, study it and accurately, and B, do anything about it from just a logistical standpoint, right? Because we're sort of if we're collecting that information but not kind of sharing it with anybody. So that's just what I'm thinking. I'm putting that out there. What do people think?
Can I add on real quick?
1, 2, anybody? 3, 4.
Yeah, I agree. I agree. I completely agree with what you were saying, Dr. Hoffman. I think I said something similar. Like, this is part of our job for the individual patient. So why conceptualize it as something different? I guess this is another kind of question for the group, is in addition to what Dr. Raven was saying about kind of screening and research, thinking about where do we want this to go? Because as far as the individual patient, this is part of our job and part of what a history should be for caring for the individual patient. But then also thinking beyond that too, are we trying to do something larger with public health? We've talked about, a lot of people referenced in their commentaries and papers, James Gordon's original paper on the ED as a social welfare institution. So might we have a role in providing for people's social welfare beyond the role in caring for their individual presenting problem? And might that then involve screening for some things that are maybe even outside of their medical complaint, but where we might be able to address them from the ED because they're not seeking other social services or kind of a separate thing. And I think that's sort of a next level beyond the care for the individual patient. And, it's an open question of how much we want to go there. And certainly it'll be harder, I think, to get traction for that sort of idea than for the idea that we should be doing this as a, part of our job as emergency physicians to care for patients. But there might be something, extra, some other benefit to be determined.
Dr. Khaldun, Dr. Lippert, then Appa.
So I think of it as in tiers almost. So there are some things that every ER doc or doc, quite frankly, can and maybe should do, dare I say. And so I think what this group could actually do is perhaps talk about, okay, you just want to be a regular doc and go home. Fair enough, that's where you are. These are some basic things you can do in your everyday practice. There's another ER, maybe you've got some champions, we call them in public health. Find the champion, whether it's a legislative champion, the hospital champion, find someone who just cares about this. This is what some basic things you can do in your ER, right? In public health, we often think about individual level approaches, organizational, social connections, all the way up to policy leverage. So maybe this group can talk about what an everyday ER doc can do, what an organizational one hospital can do, what hospital systems can do, and what are some things you can do collaboratively with others, and what are some policy levers. I think we could come up with some kind of basic, we all kind of agree somehow on as far as what are the different tiers, because everyone's going to be in a different place, right? But if we can kind of bring everyone up, wherever you are, we all kind of go up a little bit, I think we'll be successful.
Yeah, exactly.
Well, actually, the first paper did bring up this ecologic model of thinking about social EM. We didn't talk about it a lot. But
and it's what public health is, really.
Yeah. Suzanne?
Yeah, I absolutely agree with Dr. Khaldun and what many of your points actually, but hearing that it is central, it is one and the same. It's being a good emergency physician is to incorporate this into our practice. But similar to ultrasound, knowing how to use ultrasound is totally central to our practice, but there are people that specialize in it to actually continue to advance the field and really give us the research that shows us what's effective and gives us the tools to do ultrasound more and more effectively each time. So that's kind of how I envision, what we're coming together to do is like to figure out how we create that specialization along these major arms of research, advocacy, program implementation, and bedside practice, and then education. So
one of the jobs of all those others that this is a part of what we do every day, even if you're not going to do that. I'm saying that people in the room shouldn't be doing other things in the way they do. But the notion is that there's a fundamental part of this that is part of
Absolutely. I mean, and especially around the homelessness stuff too, when we're talking about it, we're also all talking about stigma too, right? And social stigma when it comes to poverty is stigmatized in our country. And then same with, the racism and sexism and all of these things have very demonstrable effects on health. And so we're talking about how do we implement changes within our bedside practice. How do we ask that question in a way that doesn't stigmatize the patient, that doesn't make them confess that, yes, actually there's some kind of failure because they're homeless or they're on the verge of homelessness, all the way up to, how do we actually make prediction rules for risks for homelessness? I mean, that I think is what's so exciting because you're right, we're trying to, absolutely, it's integral.
I just wanted to I just agree with Dr. Calhoun's comment. Sorry, I'm Appa Sahoni. I work in San Francisco at community hospitals. So I'm mainly single coverage and I work at 4 different hospitals. And it's like a race. I'm sure it is like this at your ERs. And so for me to think about, as I'm doing right now, about what I can take home to my group, which are like lifetime community ER docs. And they're about the bottom line. They are supporting their families. This is what they do. I feel like it has to be a system because we're single coverage and you're handing off the ship to another person and you can't rely on you having spent with your 24, 25 patients this time at the bedside. So I feel like for what Dr. Calhoun said, it's just really true that at the tier that I'm at, it has to come as a system. The second thing is I feel like because of this fear, both financially and medically or whatever, of readmissions, I feel like there is this, the way people jump on like a 75-year-old whom I identify as being at high risk for bouncing back. I can mobilize during business hours a case manager, a social worker, a care worker to like go home and live with them. I mean, it's like amazing, So I feel like between the hours of 9 a.m. and 5 p.m., I can treat somebody completely differently than I can treat them between the hours of 5 p.m. and 9 a.m. And I feel like there's a lot of room for developing this as a standard that we want to hold our community basic ERs to, where I want to be able to provide better care to this tier of my patients during these off hours, because that's when these emergencies happen. I can get somebody into a detox program for opiates during business hours, but I can't do that overnight. So I kind of feel like my point in this was that I really see a lot of practical steps that I need to go back to my hospital system and see what resources we have, but with the goal at a community level ER being that we want to build a system to react to these patients, because I can't rely on my colleague, bless his heart, who's in there for the bottom line, who really doesn't want to see this patient because they want to see the reimbursable 90-year-old with great insurance. I can't actually rely that I'm going to hand off this sort of a system to somebody else. So anyway, just to bring back to the screen, I don't like the term, because I agree with you, Dr. Hoffman, it's part of us getting to the bottom of it. But the reality is that when you're seeing 3 or 4 patients an hour, I want someone else also screening my patients to say, hey, you didn't notice it. Joe Schmo's here because they have 0 food security, and that's why their wounds aren't healing. Yes, I agree. Yeah, I agree with you. Yeah.
You need to change your mindset. It's part of understanding the basics.
Yeah.
Dr. Kaplan?
So just following up on the comment that was made before about asking people, getting this information as part of our history, and what you were saying before, Jerry. Doctors will do that more if they know, okay, if I get this information, then here's what I can do with it, right? That if you give me information and I feel helpless with the information that you give me, maybe next time I won't ask. So I think the key is, once again, we go back to resources. And what just struck me, it's kind of a little mind connect. ACEP right now is, and I think you're aware, we now have stroke accreditation. We now have STEMI accreditation. ACEP is now created an accreditation for geriatric emergency departments, where there are 5 different levels of being certified as a geriatric emergency department. And there are criteria that emergency departments have to meet in order to get that designation. And hospitals are going for it because it means status to them, and it means revenue to them. Now, I'm not sure that they would approach this in the same way. However, it would be very interesting to develop a set of accreditation criteria for what constitutes a social emergency medicine, a social emergency department, or something like that. What are the resources that we would expect if, in fact, we're going to ask these questions? What are the resources that we would, that ideally we would have? And it brings me back to mid-1990s when I got challenged by my CEO to create a great emergency department. He told me, you think you run a great emergency department, but our patients don't think so, right? And so what I did was I got together a group of people, and I said, what I would call, I call them my dream team. And I said, I want you to think about what would it take for us to create the best place for you to come to work and the best place for our patients to come for care, without regard to the resources that we have now or any limitations that we have right now. And then I want you to get together, meet, and present that to our ED management team, and then we'll do what we can to try to get whatever we can on that. We're not going to get everything. And in a similar kind of way, I'm wondering if we were to dream and say for our emergency departments, what would be the resources that we would want without regard to our current limitations, and understanding that we'll probably not get a significant amount of it, but what would we want all of our emergency departments to have, that if we were going to be socially conscious and look at the social determinants of the health of our patients, what are the kind of resources that we would want to provide to them? And create a list and then decide what we want to do with it. Just a thought.
Vaibhash?
So
I had this wonderful patient interaction residency when I was helping run this modest shelter-based bridging clinic for homeless patients to bridge them to primary care, to long-term primary care. I was talking to a patient. I don't remember what his complaint was, but I walked in after leaving the room briefly, and it looked like he was responding to internal stimuli. It looked like he was scolding somebody that wasn't in the room. And so we started talking about that, and to this day, I still don't know why I asked him this, but I said, do you like hearing the voices? And he sort of pauses for a second, and he looks at me and goes, well, doc, no, but I also don't like mustard on my hamburgers. It just is what it is. And so this sort of question that I asked then led us into a conversation about why he had resigned himself to not being able to take his medication, and that led it to a whole other discussion about the resources available to him, the things that we were able to provide in that clinic, et cetera. And so I tell this story to say that it's great to have resources for patients, it's great to have interventions, but I also think there is an empowering effect to asking the right questions and showing that you're concerned about the components in someone's life that you may or may not be able to do anything about, but then it provides a place for patients to come in and say, I'm here for chest pain, but I also don't have anywhere to sleep tonight. And so you hear those outright, and then it becomes a place not only for people to feel like they have a resource and an advocate, but then a place where you can continue now to gather more information about this population to then devise the interventions that we can then provide using that information. So I wanted to emphasize that there is a power in just simply asking those questions or providing the screening or doing what's necessary to make people feel like they have a place to go. So.
Seems like to satisfy the basic needs we have would be, one, we have to have, to write the universal history and physical contact with the patient, what you should be doing and determining for all patients that you're going to assess. Doesn't matter who that person is, rich or poor, and go through the basic issues. Then you'd have, as I think we talked a little bit with several at lunch, with the idea of, I think either Kelly or Maria or Jahan said, the idea of PCARN for emergency.
Social emergency.
Yeah, something like that. To really look at the problems that we're talking about and design some research projects that could be done across the nation that really look at things in big numbers and design these protocols through some committees that create something that's excellent before it goes out to work. And then really how you do, how you educate students and residents about these issues and the development of the process. I think Ed could talk about, he worked, 30 years ago, probably trying to write up a book about public health in the emergency department, an effort there, probably case studies and problems and discussing a lot of the issues. That you have some principles, you have some practice issues, then you have the design of research, and that those people who find the things that are the most appropriate to do research on, that could get the most sites involved in, that show the universality of the problems that we face and the way we would study them. Then you could figure out some of the things that we're debating extensively that probably we don't know the answers to, and that just need more methodology, more effort.
And I agree. I think there's actually, the more I think about it, even if there's nothing you can do to address the particular issue that the patient has, there's value in getting that information because it can inform what resources you do need and what potential interventions can happen in the future. And I think too often we focus on the now, the here and now, what we have now, the way our systems are now, and we're not thinking innovatively enough about like what things could be or how we can sort of change the paradigm about how we administer care, right? And if we're not the ones on the front lines thinking about these things and trying to push that agenda, other people are going to say, well, this is the way it's going to be organized and you need to sort of fix it. And so, I think there's value in having this information and being able to sort of think forward-thinkingly about, what potential ways we can change the way our systems work to better meet the needs of our patients.
think it's inherent in what you're saying, but I assume that we would be collecting this data. Because how else are we going to
you have to
show
collect
the
it,
C levels and tell them this is a problem that we need resources for if you don't have them, or identify resources that are out there because you've documented the problem. So there has to be some documentation to the process.
That was kind of what I was trying to get at earlier. It's like, exactly, is that yes, it's a part of our being a doctor and we can go and ask these questions, but that doesn't mean that they're going to be uniformly documented in our medical record for lots of reasons, right? Like someone will tell us something that we forget to put in the chart. So I think there are two reasons to do it. One is to collect data that you can do something about if it needs to be done. And the other reason is just to collect the data, just so you can show the extent of a problem, or maybe you don't have the problem. But until we start kind of gathering that information in a more uniform manner, we're not doing it right now. And so I think that's kind of a decision we have to make. And obviously it couldn't depend on, APA's shop and those people, putting in a bunch of data that are like, well, they're busy running around in their, community-based single coverage place with no residents. But I think if there are certain sites that this was like, a clearly defined like research priority, and you had people that were doing it at a couple of representative places, then that could go a long way.
Well, or even on the IDNet surveillance idea that there could be a couple of specialized centers that are pre-programmed to identify emerging needs in social welfare. And the emergency department's the perfect place to do that because we are the pressure release valve for community stress. It's a great place to measure what's new and what's needed. Stephen?
Is any emergency department routinely collecting all of the National Academy of Medicine highlighted 12 elements, 12 domains to catalyze action around social determinants? Is anybody collecting, and I put it in my paper, I'm going to, not too far ahead of myself, but I think it's germane to this, that we're kind of collecting a fair amount of this information already, and with just a little bit of a nudge, we could be collecting pretty much this essential information integrated into EPIC. And I was thinking it's the Harrison-Alter social determinant index that and when a patient arrives and we've got all the information that this index comes up for us. We've got a pulmonary embolus index. We've got all these numbers. Someone was mentioning that earlier. Why not have an index number that says, boy, you've got a very challenging case on your hands because of these domains are stressed out, they're positive, they just got evicted, or they're homeless, or they've got other elements of stressing. And what does that index mean, or how can you then research it and act on? Does this help you in decision making? Does that affect your discharge? So that's why that's one of my research questions. I thought it's just so interesting. Are we ready to have that network that Lou just suggested, of having that investigated, because we're all collecting the same National Academy of Medicine information that helps us answer some of these crucial questions.
Calhoun and positive. Do we just call Harrison? Is that
It's his index, and we call him at home and say, what do we do?
Wendy first, Joni, and then.
Yeah, so in response to that, I'm sure that those.
Sorry, Joni is first, and then, sorry.
Just to that point, and I think I spend a lot of my time in other worlds outside of medicine. There's already a social vulnerability index that has been created. This data on homelessness, there are already folks, I promise, in your city, wherever you are, who are looking at this. You have to do it. They're already doing it. So I just want to emphasize that before we, again, the hospital data is important, but before we start creating new systems and thinking that we're the first ones to gather this data, other folks probably already have it. Just maybe data sharing and bridging that gap.
Totally. Mm-hmm. So the only problem, I think, is maybe Kelly could describe the difference between what the people in the street homeless and hospital homeless and wherever all the various places, the data, at least in our city, wasn't integrated.
Exactly, data share, exactly.
And it's
that's not integrated, it's not shared.
Yeah, oftentimes the city might not even know the people who are homeless that aren't touching their system, that are touching our emergency department. So we've done this in New York, started by Maria, and I still do, like, communicating with the Department, of Homeless Services in New York City to work together and doing that together.
Wendy?
Wendy Macias-Constantopoulos from Massachusetts General Hospital. I just wanted to respond to this idea of collecting data around social determinants of health. And as was mentioned, this is being done. We're not going to be the first ones. And in fact, the Accountable Health Communities model is something that has been rolled out already across the nation. There are at least 32 institutions that are conducting comprehensive assessments of social determinants of health among their populations. And it doesn't only involve the emergency department, but in a lot of institutions it does. At Mass General, for example, it's OB, it's internal medicine, pediatrics, and the emergency medicine department. So I think some of this data is already being collected. There are assessment tools, some of them more comprehensive than others, that could be used and could be adapted to the areas. One of the things that there were so many things that I want to talk about. So I'm going to try to just focus down. One of the things that I would love to see happen is actually, I think it's been touched upon, to look at multi-site research study where we're rolling out some of these comprehensive assessments exclusively in the emergency department, following those patients into the community. Now, to be able to do that, what I think needs to happen, and this is something that, some of you may know that I, for the last 10 years, have been focusing much of my career around human trafficking, and I founded a human trafficking initiative at my hospital, one of the first academic medical centers in the United States that has any initiative around human trafficking. And I've now founded a primary care, preventative care, mental health, and intensive case management clinic specifically for human trafficking victims and survivors. So what I've learned over the years is there are 4 areas that are really important when you're dealing with populations that are extremely affected by the social determinants of health. You need to do the research for sure, and that's exactly what led to even me being able to make an argument at my institution for founding a clinic. I had to have hard evidence that this was something that was touching our patients, that needed to be addressed. And as much as I don't like pandering to the cost effectiveness, argument, that it was a cost effective way of helping our system to deal with some of the community needs. So the research is important. The teaching and education of our colleagues, of our medical students, of our residents, all that is also, an important aspect of being able to continue to drive this forward and bring in new ideas and new thought leaders around these issues. And certainly for the issue of human trafficking, I started this work 10 years ago when it was unheard of, and no one thought that it was related to what we do as physicians. Next, we need to also think about policy and advocacy, and not everyone in this group is going to do each and every one of these things, but as a whole, we need to kind of decide what areas we want to focus on. And for example, around policy advocacy, which I think is really important, I was involved in the drafting of the ASAP policy around human trafficking. I was at the CMS headquarters yesterday, arguing for ICD-10 codes for human trafficking and the logic behind why those are needed. And a lot of that is related to the research and being able to track these patients and track their needs. And then we also need to actually incorporate some of these things into the clinical care that we provide our patients. Very hard to do in the emergency department. Much easier when you're doing it in a primary care setting where you might have a lot of opportunities to get to know these patients over a longitudinal, a longer time span. But in the emergency department, we actually do have a lot of resources that we can call upon. And here is where I think each and every one of us has to be a champion for our institutions. It does take energy, it does take time to go out into the community and go out into the hospital and get to know what your hospital resources are and what community resources you have available. And they're going to vary from region to region, but there's a lot more than what I think we are aware of because we tend not to go out into our communities
So to know what resources, what organizations, who's doing what agencies have the capacity to do what, but then also not to abandon them, to work in collaboration and in partnership with them. And as you're arguing for your dollars to be able to fund your programs, we need to be arguing on behalf of them for their dollars and to be able to fund their programs, because our programs are going to rely on their programs and vice versa.
So sitting here listening to this kind of whole discussion around this, I'm kind of thinking about some ideas and processes if I were in charge of how I would try and handle this. So the first thing I would think about is that you're all sitting here talking about what the problem is you're trying to solve. You're talking about you, the physician, who wants to set up a best practice. So this group could set up the guidelines of what the very best technique is to operate you as you being a physician, working in your EDs, what you would want. Some people are saying, all right, it may be basic. Some people will be very advanced, but what's the ideal? That's what you as the physician wants to see happen. I would then begin to think about this whole issue of burnout. It's a very important topic within all of healthcare and physicians right now. You get the attention of ACGME, you get the attention of the AMA, you get the attention of every group that's looking at this right now. You have hospital administrators that know if they lose a physician to burnout, they've just lost about $300,000 or $400,000 of what they had to do to try and recruit that person, get them up and running and operating. So you take that information of what the ideal structure is that you want to see happen in ED. That's what you as the doctor wants. You can use that then to say, well, okay, if I need to do some research, here's the things that we wanted. What do we need to do in terms of research efforts to get that in place? And then you've got that to go with the burnout concept to the hospital administrators. JCAHO is going to be coming to them saying, what are you doing to help the doctors? That's already in discussion in their tablet of things they want to start looking at. So now you've got the attention of that hospital administrator to say, okay, that ideal setup that you want, we don't want to lose you. Here's some things we're willing to do to help you make it happen. I think that's the kind of thing I would think of that this group can start putting together to pull together what you're looking at for making this happen.
Catherine? We have about 3 or 4 more minutes for discussion, so you may get the last word, or?
Maybe. We'll see. Hi, everyone. I'm Catherine Wolf from UNC and Duke again. One thing that I've been thinking about as we've been talking a lot about partnering with community groups, about the need to do research. And I think it might go without saying with this group, but I thought it was worth reiterating that I think given the nature of social determinants of health and that it has to do with people's lived experiences, the stigma, as was mentioned earlier with a lot of these conditions, I think whatever research we do, we'll need to be really mindful to include patients in that research, so not just groups that they're working with, but the actual patients themselves, about what they want to be asked about, what would be helpful to them, and just really make sure to keep their perspective central to the work. And that's probably a role for anthropologists and sociologists to come and help us in doing that research. And I think it'll also be really essential in ensuring that whatever we do put into practice is successful, and therefore helps us hold on to whatever sort of tenuous support we're able to get from people who might not have bought in from the very beginning.
That means I get the last word, because we still have 2 minutes left. I have one, just a quick answer to Lou about the research network. This is in the objectives that were submitted to the ACEP board for the section. To work to create a research network. It doesn't have a name yet. SEMREN, maybe SocialEM Research Network, I don't know. And it doesn't have members and doesn't have anything yet, but it is in the objectives. And I think also it should be part of the SAEM interest group objectives, because it has a clear research emphasis, and that's really the role of the SAEM interest group, is to facilitate SocialEM research. So I don't know whether they want to collaborate on this, or I shouldn't say they, we. or whether it better belongs with one group or the other. I think we can work that out over time. But I think that the institutional support, I know there's some objection to relying on organizations for this work, but I think this is a place where organizations help. And then the other piece I wanted to try to slip in here, Jerry, for you is that, when we talk about social EM, it's not a forever thing. It only needs to be there until we transform emergency care, and then it can go away, and it'll just be emergency medicine.
I don't need for this group not to pay attention or not to read it. As you talk about specialists in ultrasound, of course we have to do that, but I'm just suggesting that the way we have to approach all our colleagues is to have them understand that it's an integral part of what we do.
Right. No, we aim to transform the provision of emergency care, to incorporate social context at the bedside, in the system, in the community, and in the population.
In the same way, I think there are many things hard for us as human beings, in particular emergency doctors, sometimes to recognize that there are things we can't fix. There are many patients, I ask them questions where they tell me something that's really terrible. The best I can do is offer them empathy. And I think that that's tremendously powerful and important and useful.
So I'm not suggesting by any stretch of the imagination that you shouldn't do that, or that it doesn't have value in and of itself. But I do believe, just as Papa said before, and as several people have said, that if we ask all of our colleagues to go and do something, and they mostly feel that it leaves them helpless, that will be counterproductive, not helpful. So yes, of course there's an intrinsic value to this, but we also have to convey the message that there's extra value when you understand that there are tools to help you use this in a way that will help your patients.
Great.
I don't think anybody's going to feel helpless by going to work to try to find a solution for someone who's homeless. I think that everyone has a shelter nearby. Someone could go spend the night in the women's shelter or the men's shelter and understand what it's like. I mean, there are lots of things you can do better if you don't know enough about it. So,
but many doctors, with
many emergency doctors, if you say there's an extra problem here, the patient is schizophrenic, is homeless, like, what do you want me to do? I'm just the doctor, and I got 5 other patients waiting. We have to give them more than just this is good. We have to give them the sense that this will actually be a tool for them to help their patients.
Just heard that one of your compatriots, so I don't know, the guy who spoke very eloquently about asking a guy who had schizophrenia what it was like, and they talked for a few minutes, and he shook his hand, he smiled, and the guy felt a little better. Both of them.
Being a good doctor. All right, thanks everybody. Let's do jumping jacks and come back and sit down in about 10 minutes.